Good afternoon, everybody. For those who don't know me, I think I know most of the people in the room. My name is Mike Ogden Brown, and I'm the counselor of the Downstate chapter of Alpha Omega Alpha, which is the Medical Honor Society. I want to welcome everybody to our sponsored events. I'd also like to congratulate all the fourth years who've gotten jobs next year. It's good to be employed, right? So congratulations on that. A few words about Alpha Omega Alpha. Alpha Omega Alpha was founded in 1902 by a group of students at the University of Chicago Medical School who wanted to raise the ethical and academic standards of those of the medical field. In those days, before the Flexner Report, medical education and the profession in general was a largely unregulated, rough and tumble sort of business. Since its founding in 1902, AOA has sought to promote excellence in medicine by extolling the virtues of scholarship, leadership, professionalism, as well as clinical and academic excellence. There are 146 chapters in medical schools across the United States. Our chapter was founded in 1948, which is before the beginnings of SUNY Downstate, so it was actually a chapter at the Long Island College of Medicine. Our chapter has long had a history of providing all sorts of services, including tutoring services for other students, organizing career planning sessions, and promoting and participating in a wide range of community-based activity. Now, for those who don't follow this sort of stuff too closely, the AOA has come in of late for some probably justified criticism, highlighting the organization's drift a bit away from its idealistic early goals and into something some people regard as a bit of an elite club. If that has happened, I suspect that's probably as a result of inertia rather than anybody's specific intent. And I'm happy to say that those of us here in the chapter have decided to take up this issue actually long before it became a national issue, and we're currently looking at revising the criteria for entry in order to take advantage of the entire breadth of talents in the student body here. And we're probably going to implement something shortly within the next month or two for the selection of candidates for AOA in the upcoming year. Now, as I mentioned, every year at this time we plan a series of events to promote AOA on campus. We have the reception next door at 3 o'clock. We have our guest lecturer here who will be introduced shortly, and this evening we'll have a dinner. We'll be hosting a dinner at which newly elected members from the student body, the faculty, our postgraduate trainees and alumni will be recognized. But I want to take a moment to recognize two people without whom AOA would mostly cease to function. The first is Sandra Mingo, who is indispensable in her attention to the care and nurturing of the chapter. She possesses tireless attention to detail and is really the person without whom the organization would not exist. I don't know if she's here. Is she sitting here? She disappeared. She knew I was going to say something about her. So the other one is Rick Sadovsky, who incidentally is our acting co-chair of the Department of Family Medicine. He serves as the secretary-treasurer of AOA. He's a Downstate alum and has for many years served actively in the Alumni Association. He is a ceaseless source of good and novel ideas, and I'm thankful for his sage input on matters relating to the chapter. And I want to ask him to come up and introduce our speaker.
Okay, thank you, Dr. Ogden Brown, and welcome to everybody to today's events. It's my great pleasure to introduce Dr. Lynn Roberts, and I'm going to introduce her by starting at one of the highlights of her career when, in 1989, she was hired by Dr. Howard Minkoff to work here as a research scientist right here in these buildings. So Lynn Roberts is somebody that has known Downstate for a long time. But let me go back a little bit further and start at the beginning of her career. Lynn Roberts graduated from Howard University, where she got a bachelor's degree, magna cum laude, and she went to Cornell University to get her PhD in Human Services Studies and program consolidations. She's been working at City University of New York for a long time and currently has the position of Interim Assistant Dean of Student Affairs and Alumni Relations. When I speak to Dr. Roberts about what she's doing, it sounds like that's a very all-encompassing job, where she has to keep students happy, she has to keep the curriculum going, and she's very involved in curriculum design. So she's doing a lot more than I would think that the average Dean of Student Affairs would be doing. Dr. Roberts has been involved in many community projects. Some of the areas of interest that she has is working with patients with AIDS. She's been involved in the AIDS Consortium and the management of AIDS here in the state of New York. And she's also been involved in many community projects that are relevant to the idea of maternal health. And I think that's what she's going to be discussing with us here today. She has a significant amount of funded research, and she should be very proud of the community projects, the gender-based research that she's done, and the HIV prevention and care research that she's done. And she's also well published in the area of reproductive health. So I think Dr. Lynn Roberts is here appropriately to speak on the topic for today. I'm very happy to welcome her. She gave a talk to the Family Medicine Department, and I understand to the Obstetrics and Gynecology Department at Maimonides here, not too long ago, and has a lot of information on a topic of great importance to all of us. So Dr. Roberts, thank you for joining us today.
Thank you. Thank you so much for that wonderful introduction. I did want to start with introducing my talk, of course, is on medical praxis, a primer on reproductive justice for physicians. And I'm sure some of you might be very curious what that all means. So I hope by the end of this hour with you, you'll have a better understanding and hopefully an appreciation. But I would like to begin with at least some acknowledgments. So I'd like to take a moment to thank a few people. And I'm going to begin, and she is not here, with Ms. Sandra Mingo, because she guided my steps these past several months to ensure that everything was taken care of well in advance in order for me to be here with you today. Dr. Ogden Brown, thank you also for inviting me, and to Dr. Richard Sadowski for being such a gracious host this afternoon. And last but certainly not least, Dr. Howard Minkoff for probably talking them into this, I suspect. Maybe not. So again, it's a pleasure to be here. It is a bit of a homecoming for me. It was my very first job in New York, and to work here with Dr. Minkoff. And so just to be in these quarters, I don't recognize a thing. It's changed a lot. Because I remember being crammed on a floor somewhere and around nurses. But this is beautiful, so congratulations. So I'm going to share with you my journey and a bit of my own story of how I came to reproductive justice as something that I wanted to pursue as a scholar activist, which is how I identify myself. So I'll begin by sharing that I began my foray into research as a research subject in 1979. I was a 17-year-old when I had my first child. So I was what was considered then a teen parent. I had been dating and doing what a lot of adolescents do. And it isn't that I wasn't aware of contraception. I was practicing that method that they talk about. And you know what they call the people who use this method? Parents. So, and it worked. But just to put it in some context, it was during the tail end of the President Jimmy Carter. I hope some of you, remember him. But it eased into the Reagan era and what many people now refer to as a war on the poor. And my experience as a young parent, which is the preferred term because to call someone a teen parent often has connotations that are rather pejorative and negative. At 17, I worked every Saturday and Sunday as a nurse's aide in a local nursing home. I maintained very good grades, and I managed a household. My parents were divorced. I chose to live with my father when they divorced in order to stay in the town where all my friends were. Given the choice of staying in the town I grew up in, Bethlehem, Pennsylvania. Anyone from Pennsylvania? Steel town, and at that time, still a thriving industry. It was some years later that all went, south, and now that steel mill is a casino. So maybe you've heard of the Sands Casino. But as a young adult and a young teen, I felt very mature and responsible. And during that time, with the young man who I was dating at the time, and when I became pregnant, did not feel I could share that easily because it was so, it was considered such a negative thing to be a teen parent in 1979. There were headlines in newspapers saying, babies having babies. To me, it was probably the worst thing you could be next to being a communist during the Cold War. So my experience transformed from a small town where I grew up, where I did not reveal my pregnancy to anyone because I didn't know how they would respond. So I did not get prenatal care for the first 5 months or so, until my father inadvertently discovered it. And within a few days, I was moving to my mom's because he didn't know how to handle. He wasn't very good at handling my mother's pregnancy, so he surely wasn't going to be very good at handling mine. So I moved to a very different environment, an urban environment, from being in a suburban environment all of my youth. And I'm going to give you a little bit of the demographics that we usually associate with things such as teen pregnancy. So both parents, college educated, employed at middle-class jobs, lived in a suburb in a split family house, all those things. So none of those things that were typically associated with being a teen parent at the time. It doesn't mean that they weren't associated, but most people did not think of that as the profile of the teen parent whom they were demonizing in newspapers and even in some of the research studies at the time. And I didn't know that at the time about the research studies. I looked those up afterwards for that era, and I've written about it. So I did experience when I finally did go for prenatal care, and also it was necessary because my mother was living on her post-divorce income and wasn't expecting to take in a daughter who was pregnant and worrying about medical care. So I applied for social benefits, which I was eligible for at that time, based on her income and my living in her home. So I received public assistance. I got Medicaid to pay for my obstetrical care. But it was the shame and the demonizing that I also experienced. So when I presented at the local hospital, that made the most sense. My mother was a Howard graduate, and I decided to we went to Howard University Hospital. And I will say that even though I saw a private obstetrician, I didn't expect that when I eventually delivered that I would be treated so poorly. So the day that I went into labor, my mother took me to the hospital and essentially did what had been done when she gave birth. She basically dropped me at the hospital door. Probably because she wasn't accompanied during any of her, deliveries. She didn't think that maybe I might need someone to stay with me. So she went on to work and trusted me to the care of, the medical team. And I will say that I felt I was, not properly treated. Let me just say this. And this is with, again, I had a good relationship with the obstetrician up to that point, but I really felt because of my age, I was treated poorly. Some of the examples, I was left in a corridor to get an x-ray taken because they didn't think my labor was progressing quickly enough, and they thought maybe my pelvis was too small. And they weren't informing me what was going on, so I just waited. And then I was told I was going to have a C-section, without explanation either as to why. Mind you, 1979, the District of Columbia had one of the highest rates of infant mortality in the country. And I, again, to this day, I'm not sure whether that was under medical advice or was that just because of my age and a precaution on the part of my doctor, who happened to be a black physician of Caribbean background, if that's important. So I couldn't say I was discriminated against because of my race. I do think I was discriminated against because of my age. I was not offered the option to breastfeed my daughter, who was born healthy, and I don't know why. It was April. I was going to graduate high school in June. I was scheduled to enter American University and study business. That was my plan. And that summer, I stayed home with my daughter, fell in love with her, and didn't feel I could leave her. So I deferred my enrollment. And in the meantime, because I was part of a study, I was recruited to be a part of a study because of my age on, guess what, teen parents. And the interviewer came to my home, asked me a lot of questions, and I said, this is curious. I'm being asked a lot of questions. Can you tell me a little bit more about what you do, what you're studying? And long story short, I never ended up at American U studying business. I ended up at Howard University in their Department of Human Development. I ended up doing my work study with the PI, the principal investigator of that study. And 2 years into my studies, ended up coding the data in the study I was a part of. So, as I said, I began my foray into research as a research subject. And the one thing that stayed with me was that when that I thought I could ask better questions, that I was intrigued by this idea that, they're trying to figure out how a nice girl like me got pregnant. And it seemed that their questions focused on things like locus of control and self-esteem, which I didn't think my self-esteem was too bad, or not much different than many of my peers. And yet, those were the types of questions that were asked, and maybe a few other things about my family and the history in my household. And again, I didn't think any of that had anything to do with the fact that I had used a method that just didn't work, or that I had some circumstances, and that I was, just as capable as someone else at that age who had a lot of the benefits I had and resources I had to become a parent. In fact, when I entered Howard University that fall, the year after, when my daughter was a year old, and I enrolled her in a Montessori program and eventually transferred to the early childhood program on campus, so I got to spend time with her even while I was studying, because I could go into the observatory room and watch her while I did my homework. How cool is that? Who gets to do that? It was a perfect situation. And compared to most of my peers, at that age as a college student, undergraduate, I was much more focused, because I had someone to take care of every night and planning for their future. So I was a very highly motivated student, and I was learning and studying about human development while I was raising a child. So I think that made me an even better parent than I might have been otherwise. And someone might say, well, you're the exception, right? Because most of the studies that you read about teen parenting predict that they will do poorly, they'll have poor economic outcomes, they'll be a burden to society. But I think it has a lot to do with what we provide to young parents, both before and after a pregnancy occurs, and also what enables them to make the best decision they can make for themselves. I truly did not want to abort my pregnancy, but I respect others who were my peers who chose to do that. So I was not the only one in my peer group getting pregnant, but I was one of the few who chose to have and keep her child. So from there, from that experience at Howard, I went on to Cornell. In fact, I'll tell you a little bit about my departure from Howard. Was that I told you I was receiving public benefits, and the caseworker, when I told him I was going to be leaving the area so he would have to close my case, his first question was, I didn't know you could do that, meaning he didn't know I could receive public benefits and go to college, let alone go to graduate school. And I figured he wasn't telling anyone else on his caseload they could either. The other thing I did while I was at Howard, I studied the policies that impact many people on public assistance. I studied the AFDC program, Aid to Families with Dependent Children, which it was then called, now it's called TANF. But I was really interested in the policies that impacted the provision of services, and I was well aware of what I was entitled to. So from there, at Cornell, I discovered that that institution had run a migrant farm labor camp at some point in the 70s. And when I learned about that, I was intrigued. I had thought that was something that had been resolved back in, an earlier era. And I was very familiar with the farm labor movement through my father, who actually directed the War on Poverty program in the Lehigh Valley of Pennsylvania. And he was, before that, a migrant chaplain, because he was also part of the ministry. And so when I get to Cornell University, I learned that they had run a migrant labor camp. And when it leaked that there might be some possibility that they would get some bad press about that, they closed the camp and opened up a service program called the Cornell Migrant Program. So in 1984, when I was there, I learned about what was going on in that region of New York State with the workers who came to the area to pick apples. And I did a participatory research study, which means I lived in the migrant labor camp and picked apples alongside the workers. I also interviewed workers and employers and service providers to compare those who traveled as single, unattached men versus those who migrated as families, and in terms of the differences in the service delivery systems to them. So that was my time at Cornell. I moved to New York, and that's when I first came here. I was ABD, all but dissertation, and getting a little restless. By then, my older brother was actually living with what was known as ARC, AIDS-related complex, before we even called it AIDS. And I wanted to do something, and I saw an ad in the paper for a HIV research interviewer. And I went through a wonderful interview process that Howard's team coordinated, where a group of us were interviewed, and many of the people who interviewed with me were people from this neighborhood, right around Downstate. And I don't think it was you, Howard, but I think it was Bob, who was his research coordinator, who thought I was overqualified. Like, why would you want to apply for this research interviewer position? But at that point, because I was trying to finish writing my dissertation, I didn't want something too demanding. I wanted something that got me involved, and then I could, write, in the off hours. And that worked out very nicely. I learned a lot from Dr. Minkoff. Much respect for his work and his innovative ways of engaging with community members who were most at risk for HIV. And if there's time, I might share a little story, but I think I'll do that afterwards, with his permission. And I did leave rather prematurely. Howard applied for a supplement, an NIH supplement to his research grant, and I unfortunately left without accepting it to take on a position with the AIDS Institute, which is part of the New York State Department of Health. So for several years, I coordinated HIV services, mostly for young people in East New York, Brooklyn. And then I had an exciting opportunity to direct a program with the Visiting Nurse Service of New York, which was part of a larger complement of programs known as the Family Rehabilitation Program during what we referred to as the crack epidemic in New York City. And I directed one of 20 programs in Harlem to provide comprehensive services so that women who gave birth to a child with a positive toxicology for an illicit substance or alcohol got referred to them, and instead of being punitive and removing their children, they provided treatment. Imagine that. So for this period of time, these 5 years in New York City, these family rehabilitation programs provided this, comprehensive services, as you can imagine. Our program in particular, each family had a visiting nurse, a case manager, a substance abuse counselor, a parent aide, and then a complement of services that we provided on site at an outpatient drug treatment program. We actually provided the drug treatment. It was designed by and for women. So that was pretty exciting. And we were able to do that for those 5 years until a new administration came in, switching from Dinkins to Giuliani, if anyone remembers that period of time. And those programs were the services for the substance abuse services were disentangled from the drug treatment or from the preventive services of foster care placement. And as a result, our program, which did both, was no longer able to sustain itself. And so I came in the back door of the academy because I was offered a position at Hunter College where I worked at a research action center where we were delivering programs for youth and women around HIV and violence prevention. And I did that until a faculty position opened up. And since that time, have worked on several research studies on youth violence and intimate partner violence among youth in Bronx high schools. And somewhere along the way, I discovered reproductive justice, which I'm going to talk to you about. And it was there that I became very involved with working with others who were doing reproductive justice work across the country. It culminated in 2017 with the co-edited volume of an anthology called Radical Reproductive Justice, and it has a longer subtitle. But right now, my primary pursuits are around bringing this framework into settings where people, in particular providers of care, are interacting around many issues related to sexuality and reproduction. So in a nutshell, that's who I am. I know it's a long-winded way to tell my journey to now, but I think it's relevant to what I will present about reproductive justice. So what exactly is reproductive justice? I'd like to begin by first saying that it's a direct response to reproductive injustice. And I gave you some of the examples of that in my own story. I alluded to that in my mother's story. In fact, my contribution to the anthology that I've written is about 4 generations of motherhood in my own family. My maternal grandmother had 2 sons and 2 daughters. My mother had 2 sons and 2 daughters. I had 2 sons and 2 daughters, and my oldest daughter, the one born in 1979, now has 2 sons and 2 daughters. Through a variety of means, through both birthing them and adopting them, and in each of those eras, there were public policies that impacted our reproduction and the choices and options and the level of respect and support that we received or more likely did not. So reproductive injustice refers to the control and exploitation of cis and trans women and girls, and that's been a broadened category, and other marginalized people through our bodies, our sexuality, our labor, and our reproduction. And this regulation of our bodies thus becomes a powerful strategic pathway to controlling entire communities. It involves social injustices and systems of oppression that are based on race, ability, class, sex, gender, sexuality, age, immigration status, and other statuses. But there's also a historical context to this. And it's really important to be able to think back historically to some of the events that have transpired to influence some of the things or foreground some of the things that are happening today. So in addition to the exploitation of their labor, enslaved women of African descent were often raped and forced to breed only to have their children sold as chattel. And most notably, it was between 1845 and 1849 that the founder of modern gynecology, J. Marion Sims, experimented on enslaved African women and their infants without anesthesia that was available at the time to perfect surgical procedures for white women. But we also had the forced sterilization programs visited upon Puerto Rican women, African American women in the South, in what Fannie Lou Hamer pictured in the middle there was also called a Mississippi appendectomy. We had the eugenics movement to increase births among the fittest and decrease births among the unfit. From the late 1800s until the early 1970s, Native American children were removed from their families and sent to boarding schools to civilize and remove, quote unquote, the Indian from them. there's also a current context. So more recently, we have witnessed restrictions on comprehensive sex education in schools, coercive use of contraceptives, restrictions on access to abortion, discriminatory early termination of parental rights, the separation of children from their parents through foster care and immigration enforcement, and the demonization and criminalization of pregnant and parenting people based on our age, our substance use, and being poor. And I could go on. And I'll also mention how many folks are aware that New York State only recently passed legislation to end the shackling of pregnant women who are incarcerated. It was done in 2009 and again in 2015. And even with that legislation, it still happens because this is the whole state. And, you know, if a woman is incarcerated, sometimes she has to go out of the facility for her prenatal care visits, and they will literally, you know, place a chain across her abdomen and keep her, shackled during labor. And that can only be stopped with monitoring, but it's very hard to monitor that within institutions. And I've talked to physicians who have been in those contexts where the guards control everything that happens. So it's a very delicate position to be in. I don't know how many are OB/GYN student residents. Well, I mean those who are entering. I know we have some of the faculty, but I know it was match day, so anyone going into obstetrics, you're already in it. Okay, so from hearing mingling earlier, I didn't think many of you were. So again, not many people are aware that they might think that's something very draconian that happens in other parts of the country or not in the US at all, but it indeed does happen, and it's very hard to change that even with change in policies. And I will say that those who forced that legislation were formerly incarcerated women themselves advocating on behalf of having the laws changed. So it is within this context of reproductive injustices that reproductive health inequities emerge. New York City Health Department's, New York City's Pregnancy-Associated Mortality Surveillance Report by the New York City Department of Health for 2008 to 2010 found that black women in New York City are 12 times more likely than white women to die from pregnancy-related causes. And between 2006 and 2010, when the overall pregnancy-related mortality ratio was 21.9 deaths per 100,000 live births, but for black women it was 56.3 deaths. And while there has been an overall decline in New York City between 2001 and 2010, it hides a widening racial gap, which is largely driven by a 45% decline in pregnancy-related mortality among white women. So as it's actually dropping for white women, it widens the gap. And it's higher among all racial ethnic groups in this study compared with white women. Asian Pacific Islander women are more than 4 times as likely, Hispanic women more than 3 times as likely. So given this, reproductive justice is just one of 3 frameworks that has emerged in response to reproductive injustice. The other 2 are reproductive health and reproductive rights. And all 3 are critical, and they are not mutually exclusive, but it is important to distinguish them. The 3 frameworks most often must work in concert with each other to achieve health equity and other human rights. So looking at these 3 models, reproductive health is the service delivery model, and that's where the work of healthcare providers such as yourselves falls. And it focuses on addressing the unmet reproductive health needs. And the constituents are typically patients in need of those services. And the providers are those who are allied with medical professionals, community and public health educators, health researchers, and health service providers. Reproductive rights is the legal advocacy-based model. It protects the individual's right to access reproductive health services, and individuals are encouraged to actively participate in the political process. The primary players are advocates. And then there's the reproductive justice framework, which is an organizing model. It focuses on intersectionality as a way to organize communities to change structural inequalities. The constituents are community members who are organized to lead against reproductive injustices. And the key players are organizers. Those who work as or are allied with reproductive rights, reproductive health, and social justice and other justice organizations. There are hallmarks of each of these. With reproductive health, again, focusing on needed services, but the limitations are that oftentimes the services and education are directed at the individual level and do not address the fundamental root causes of the conditions. So this focus on just the individual can sometimes make it difficult to also engage with the social determinants of the needs of a particular community. With reproductive rights, it also focuses on individual choice and often obscures the social context in which individuals make choices. It assumes a level of knowledge and access to elected officials and belief in the effectiveness of the political process. People marginalized by immigration status, their age, class, race, ethnicity, disabilities often do not have this access or knowledge or faith in the ability of the system to respond to their needs. So the reproductive justice framework is a reframing. It understands the historical context of the control of particular communities and its consequences on their health and well-being. And it stresses the importance of listening and respecting the self-determination and bodily autonomy of all people, especially the most marginalized. And the practice of humility and taking risks toward deeper engagement with those who are most marginalized in our society. So who's ever seen this image? And so the difference between equality and equity, which we talk about much more in terms of health equity, right, is that equality is you treat everyone the same. So in that image where you give everybody a step up, regardless of their individual circumstances. Equity, you don't treat everyone the same, you treat everyone according to their needs. So you might give someone a little more than a step up, 2 steps up if that's what they need. That's pretty clear. A more accurate depiction, though, might look like this. And still, with justice, you would just tear down the fence. And then everyone could play instead of being bystanders watching something in which they're not engaged, such as a sport. And everyone could play a new game with new rules. So a definition of reproductive justice is when all people have the social, political, and economic power and resources to make healthy decisions about our gender, our bodies, and sexuality for ourselves, our families, and our communities. Reproductive justice aims to transform power inequities and create long-term systemic change, and therefore relies on the leadership of communities most impacted by reproductive injustices. And it recognizes that all individuals are part of communities and that our strategies must lift up entire communities to support individuals. The term reproductive justice was coined in 1994 by a caucus of 12 black women while attending a conference in Chicago sponsored by the Illinois Pro-Choice Alliance and the Ms. Foundation for Women. I would call their names if we had more time, but these founding mothers were looking for a way to articulate the needs of communities of color that face multiple forms of sexual and reproductive oppression. 1994 was also when healthcare reform was first being introduced by the Clinton administration. They were very concerned that that proposal did not address their specific needs. And they thought that it needed to be, much more sensitive to the unique needs of low-income, indigenous, and women of color. So while the theory, strategy, and practice of reproductive justice have evolved over time, from the outset, the framework has built in recognition of the need for an intersectional analysis defined by the human rights framework based on the practice of self-help and community care that would be inclusive and applicable to everyone. So I'm going to go through the first the three key elements of this framework. The first element of reproductive justice is intersectionality, in which we address the intersecting systems of oppression and health inequities. Intersectional analysis of the root causes of health inequities is essential to securing the human rights of all people. The term intersectionality was first coined by critical race scholar Kimberly Crenshaw and later expounded upon by Patricia Hill Collins in her seminal book, Black Feminist Thought, Knowledge, Consciousness, and the Politics of Empowerment. I will also note that there is a long history of intersectional analysis and organizing that predated the actual use of this term, from Sojourner Truth asking, "Ain't I a woman?" to Anna Julia Cooper reminding us, "Only the Black woman can say when and where I enter in the quiet, undisputed dignity of my womanhood without violence and without suing or special patronage. Then and there, the entire race enters with me." To Frances Beale's book Double Jeopardy in 1969, to Toni Cade Bambara's The Black Woman in 1970, to the Combahee River Collective Black Feminist Statement in 1974, in which they wrote, "It is the synthesis of these oppressions that creates the conditions of our lives." The second element of the framework is, the second foundational element of the framework is human rights, which are generally defined as those rights which are inherent in our nature and without which we cannot live as human beings. They are universal and apply to all persons. They're not restricted to any protected class or group. They are based on humankind's continuous and increasing demand for a life in which the inherent dignity and worth of each human being will receive respect and protection. If you're not familiar, and this past year, 2018, was the 70th anniversary of the Universal Declaration of Human Rights. When these rights are threatened for any of us, they threaten all of us. These are the 8 categories of human rights, and they all are considered important and relevant to our health and well-being. The third foundational element is self-help. This originated with the Black women's health movement in the United States. You might have heard of Billie Avery. It spread internationally by the National Black Women's Health Project and the National Latina Health Organization. It's been used in the women's health movement by HIV/AIDS groups and amongst indigenous and women of color groups throughout the United States. And the whole concept in regard to the reproductive justice framework was that when people who have been traumatized, historical traumas, generational, intergenerational traumas, they often, when they come into working with each other to do something about that, can sometimes inflict harm on each other. And so the self-help in community is geared towards ensuring and protecting that from happening through constant reflection and support of each other in healing spaces. And it was built into the organizations that adopted the reproductive justice framework from the beginning, incorporated it into their organizational structure, their meetings, every time they come together, practicing some elements of self-help and community care. There are also 4 key principles of reproductive justice, which refers to the human right to decide if and when you will have a child and the conditions under which you will give birth or create a family. Second, to decide if you will not have a child and your options for preventing or ending a pregnancy. Third, the right to parent with the necessary social supports in safe environments and healthy communities and without threat of harm from individuals, organizations, or institutions of the state. So imagine if every young parent like myself knew that they could pursue a college education and was afforded the resources to do so. Or if every individual who decided that they didn't want to do that did not have to cross state borders in order to do so. Or that a parent who had a substance abuse problem did not have to forego seeking treatment in order to ensure that they could keep their children. So again, this third principle is one that often doesn't come up in the context of talking about reproductive rights or reproductive health, because those models tend to polarize folks around being pro-life or pro-choice. The reproductive justice framework embraces an individual person's right to make that decision for themselves and not impose, any restrictions on anyone else based on the choices that they make, and recognizing that there are different contexts in which people may be constrained in making those choices. And in that respect, the fourth principle of bodily autonomy from any form of sexual or reproductive oppression. There are several strategies of reproductive justice. First and foremost is to analyze and work to change unjust systems of power by really changing the discourse and the narrative around what can be done. So oftentimes that means working within existing systems to come up with different ways of both looking at what data exists, collecting data, analyzing it from this perspective, and also coming up with the solutions. When necessary, another strategy is to take direct action. And that includes, or can be defined as, confrontation that, if successful, ultimately leads to negotiation with those in a position of power to make decisions that will address the root causes of a social injustice. So this was a group of us outside of Governor Cuomo's Manhattan office, and ultimately he did sign the 2015 legislation, but that doesn't mean that the matter is resolved. It also means another strategy means recognizing and supporting the leadership and power of those most excluded groups of people within a culturally relevant context that identifies and addresses the multi-layered impact of oppression on their lives. It means centering the marginalized, those who've been most marginalized in their communities, and supporting their leadership. And often, the folks who are most marginalized in reproductive justice settings frequently show up for others, but others do not always show up for us. And when they do, it is often too little and too late. Supporting our leadership entails providing sustainable long-term funding, supporting capacity building, consulting prior to and not after new initiatives, bringing folks to the table when making decisions that will impact them, sharing resources, sharing the credit, and educating ourselves and practicing being better allies to others. And I say that because all of us can be an ally to someone else, because none of us share the same intersectionality as anyone else. So everyone has relative advantage to someone else based on some characteristic or status. And so we all can work on being better allies. Another strategy is to build and sustain a power base. And this means developing the leadership and building the social and political economic power of those most impacted and their communities so they can survive and thrive. We listen to, engage, and mobilize communities most affected, and we create opportunities for those new leaders to emerge. We also coalition build with allied social justice organizations. Some of those might include human rights, civil rights, and racial justice, LGBTQ rights, environmental justice, workers' rights and labor unions, faith-based organizations, housing rights, immigrant rights, single-payer healthcare reform, sovereignty, and I could go on. The potential for radical transformation through reproductive justice can alarm or make cynics of many across the political spectrum. We educate our current leaders about, our current electeds, that is, about reproductive justice, and we groom and support new candidates for office. We also encourage voter registration, educate the public on the issues, and we constantly fight against voter suppression. And finally, we use the strategy of storytelling. Through storytelling, or what I call we-search as opposed to research, we reveal stories of human rights violations, acts of humiliation, violence, and exclusion. We validate a person's humanity and acknowledge the whole range of emotions that we experience. And we use self-disclosure to initiate healing and collaborative processes of restoration. There are other strategies, but these are the ones that are most often used in my direct experience applying the reproductive justice framework. So what is Praxis? When I think of it, I'm referring to the work of Paulo Freire and his idea that power cannot be taught or given, it must be asserted or reclaimed, and that ultimately the underlying root causes of social health problems must be identified and addressed by the people who are experiencing the problem themselves. And we engage in this type of praxis through active listening, critical reflection, analysis through dialogue, and taking action. So it's this combination of reflection plus action that is often referred to as praxis or conscientization. But my Portuguese isn't very good. So reframing medicine with a reproductive justice praxis, what would it take? What would it require? First and foremost, it requires those who are centered in the health disparities data must be centered in the decisions made to address those disparities. So listening to and amplifying the voices of those who have been most impacted by reproductive injustices and health inequities and turning to them for solutions is critical. What does this look like in medical praxis? Treating each patient as a person with a story and not a bundle of risk factors. Engaging in participatory models of care and research that center those most impacted by health inequities. Taking risks, including political ones, on behalf of your patients. Utilizing your power and influence to dismantle oppressive systems that perpetuate health inequities. And as always, staying humble. And these are just some general themes, and I wanted to illustrate an example of doing this that I'm engaged in with the Department of Health here in New York City. And for that, I'm going to share a brief video and to give you some background. So you can get to this site yourself if you go to newyorkcity.gov and then Google SRJ for sexual and reproductive justice. It takes you to our page. So how this came about is that in 2014, two of my former students, I now teach in the CUNY School of Public Health in the Community Health and Social Science Department, or at least I did until I went on leave to become the interim assistant dean. And I have been teaching for the past 20 years a course that all MPH students in my department are required to take on community organizing and community building for health. And so often I've talked about reproductive justice in that classroom. Two of my former students were interning at the Department of Health in the fall of 2014 when they were getting ready to launch a campaign about the IUD. And it was their suggestion as they were planning a staff retreat to suggest that maybe I should come and talk to them because this particular campaign, even though it was to talk about the IUD or LARCs, long-acting reversible contraceptives, was also very focused on this particular method as the most effective method. And there were concerns that the promotion of this particular method above all others was not in keeping with the reproductive justice framework's quest for bodily autonomy. So I went to the department staff retreat and their sexual reproductive health unit, and I gave a similar talk to this one, maybe a little more detailed, about reproductive justice, and all these light bulbs started going. They said, oh, we should maybe reconsider this campaign a little bit. Why don't you and others who are doing this work help us plan a stakeholder meeting? So that June of 2015, we did just that. And from that, the sexual and reproductive justice community group was formed. So it was through this process that this group began meeting with the Department of Health, and they, through the former Commissioner of Health, Dr. Mary Bassett, decided to adopt the sexual and reproductive justice framework and incorporate it in their work and activities. And we've been working with them for the past 4 years. We're wrapping up the 5th year of resources that were dedicated. So I won't be able to show the video. So we created in the first year a video to introduce the framework to those who might be working in settings where they come into contact with folks who would most likely want to make decisions about their sexuality and reproduction and would benefit from the framework. We were able to also work in a different way. So institutional transformation became a very important part of our work with the Department of Health, so that they were doing things a little differently. So in the past, a video would be developed by the communications department, and they would hire a vendor who would work with them. But at this time, we actually were able to bring in the community engagement group to work with folks and design the whole video, which I really regret I won't be able to show you. But if you might get a sense that when community is engaged in something and they feel like they're a part of it, you get a different result. Okay, all right. So we've been working with them. Another outcome of this community engagement group was that we were very concerned about the high maternal mortality rate that I shared with you earlier. And we were able to, through a democratic process, we were able to work with...
What first brought me to reproductive justice wasn't my experience of having an abortion. It was actually my experience of giving birth. I was pregnant during law school and at the time was a Medicaid recipient. Decisions were made about me without my input. We would ask questions and people literally ignored us.
When it comes to sexual assault, I've had 4 incidences in my life that I can remember. What I did initially, before I talked to somebody, before I got counseling, self-medicate. I felt guilty. I felt like it was my fault.
The first time that I had an abortion, I went into the waiting room and was so shocked to see another Asian woman in the room. If you're dealing with issues related to your reproductive health and you're not seeing your community or your stories reflected in that conversation, you're all alone.
I would have loved if there was sex education in my schools. It would have been great to see 2 women in love, and especially 2 Black women in love. But there was no visibility for people that look like me.
Sexual reproductive justice, had I been exposed to it younger, could have changed the way I valued myself.
We have to acknowledge that there is a history of women being coerced into contraceptive choices that were not ones that they either understood or chose.
The experience of being treated as a non-person really made the cesarean surgery traumatizing and frightening in a way that it really didn't have to be.
No woman wants to have crappy schools.
A parent has the right for their child to grow up healthy and happy and affirmed.
My body is my body.
No one, no entity, no clinic, no boyfriend, parent can make decisions for my body.
Coming from an immigrant community, there wasn't a lot of trans-friendly services or trans-knowledgeable doctors that I knew of growing up.
Black women in New York City are 12 times more likely to die from pregnancy-related causes than white women. And this is just one of the many inequities that a sexual and reproductive justice framework seeks to correct.
To see government agencies bringing us together to hear our thoughts about sexual and reproductive justice. That is a very big, huge step.
In order to heal our community, we need to hear from everyone.
Your voice is important. We want to hear from you.
Thank you. Dr. Roberts has a limited amount of time, but we can try and ask a couple of questions if there are any from the floor. Does anybody have any thoughts?
Well, first of all, I just wanted to say how proud I am that we had our one moment of intersectionality. Of course, I was a teen volunteer at the time, so I don't remember that well. But I will say, as an obstetrician, it is a stain on our profession, the disparities that we see, and I would have no difficulty for me is trying to bring it from something aspirational to something operational.
Mm-hmm.
And I'm willing to go all in, but most of what you described is from outside coming in.
Mm-hmm.
So, we try to set up the community advisory board, things like this, but is there a model, is there a best practices that hospital X had terrible disparities and then they did this and it's now better, and go call them up and ask them how they accomplished it?
Not yet, but we would like to be a part of that.
Can we just repeat that? I don't know if
Yes,
everybody
so the
heard
question was, are there good models or examples of hospitals and settings where people have applied this and done really well and, reduced the disparities? And I would say not to my knowledge, but I think we're working on it here in New York. And I think we're working on it in a variety of ways, and it's not going to be, it is aspirational right now. And the practical side of it is that it requires a willingness to engage in a process differently than what people are accustomed to doing. So, and I'm seeing one of our members of the CEG, and who's been doing this work long before we had a CEG. Hi Denise West. Being able to challenge how things are currently done without saying, that, you're intentionally causing these disparities or alienating the providers who provide quality care. So we have certainly individual providers, and we have, settings where people do the best they can with what they have. What we're proposing is to work in dialogue with community members around how things can be done differently and in innovative ways. And one of the things that came out of the CEG, working with the Department of Health, was the development of a standards for respectful care at birth. And this, again, based on the framework and human rights, is now being introduced in healthcare settings. We're hoping to bring it to every maternity hospital in New York City. They're starting a lot here in Brooklyn, but this is not unique to any hospital, right? Every hospital has troubling outcomes. I think we can all agree on that.
Right.
I think it's more about being able to think about how we provide care given the constraints, even for those who are the providers of care. So the same things that impact communities also impact providers, right? The 15-minute visits and the insurance reimbursements and the challenges of having to meet administrative quotas, right? Those are realities. And so being able to figure out ways that we can be innovative and think about, especially for those of you who are coming newly into the profession, if you will, because I think you can make a difference. Not to challenge those of us who are older and been around, some of us are just tired. And I think there's different levels of risk taking. So when I say take risks, I think those of us who are older can take risks that younger people can't afford to take, and just the opposite, younger people can take certain risks because you may be fuller of new and innovative ideas that us older folks haven't considered, right? And the difference in risk taking is that you can be too comfortable and not take risks, or you could be maybe a little more, open and wide-eyed and not anticipating that you have any consequences, right, in taking risks. But I think everyone should be willing, and if we do it collectively, then guess what? The risk is diminished when we do things, collectively and bring these things to the attention, because, sometimes, we've met the enemy pogo and they are us, because we're comfortable or expect that we can't change the system, right? That it's always been this way, and what difference would it make? But having these conversations, if anything, that's what this is. Like, the standards may seem, we can't achieve all this, ensuring this. There's all kinds of constraints on the day-to-day operations, and we've been told as community members we don't understand that. No, we understand that, because even providers have been patients, and you've seen the difference in the different levels of care here in this city, between where you might receive care, and receive care as the person you are. So sometimes what's harder is for people to realize what it means to, receive care and enter these systems as someone else. I don't know what it's like. I'm a cisgendered African American, woman. I don't know what it's like to be a trans, lesbian person. So even those subtle differences and what it means to access care and have my questions answered and have my concerns listened to.
Just a brief addendum would be, I think there are people here who could speak of this more than I can, but the New York City Department of Health has a multimodal actions going on right now.
Absolutely.
To try and resolve some of reproductive injustice.
Absolutely.
And some of them are aimed at hospitals and caregivers. Some of them are aimed at social organizations and community organizations. And some of them are aimed to empower women to actually request and demand social justice from their own politicians.
Absolutely.
So I know there are people in this audience who know more about that than I do. But there's a lot of activity going on in many ways. We have time for one or two more questions or comments.
Thank you so much. This was a really wonderful talk, and I really.
You have people all the way over there.
I just wanted to say thanks for the talk, and I'm really glad that you looked at reproductive justice across the spectrum of identity and orientation. Has this framework been applied to women with different level of abilities? So I've been working with a group of women with different levels of abilities who said that they see a woman, they see a wheelchair, and there's no discussion on reproduction at all. So I was just wondering if that.
Not as much as I would like us to, but they are certainly included in our efforts. And I should have added, and able-bodiedness also occurs along a spectrum. Like all of us may have moments of different ability and able-bodiedness. And so, again, these are all areas of learning and learning to become better allies in supporting that work. And it means bringing in the individuals and the organizations that, provide those services. But everyone is welcome. This CUG meets monthly for 4 hours. How many times have you seen a group meet for 4 hours at a time? Denise is smiling because it's hard. You have a job or other commitments. It can be school, whatever it is, family. It can be very hard to spend 4 hours once a month. And then there are work groups that meet too in between. So it's a huge commitment of time. Many people are not paid for their time to participate. We were working a lot to provide this support. So all the things that that Richard just mentioned are actually things that the CEG is also working up and part of with the Center for Health Equity and others. We're doing a lot of work. We're doing grand rounds. That's how we first met here at Downstate, doing grand rounds with providers. And that's a broad category of nurses, midwives, doulas, physician's assistants, not only physicians, and having difficult conversations with one another to really probe how can we make this practical, as Dr. Minkoff suggested, Yes?
I just have a question about how you accomplish it in resources. So last I heard, Health and Hospitals Corporation is facing $1.8 or $1.5 billion deficit.
Excuse me, can you stand up perhaps? The way this room is designed, there are people all the way down there.
So I've been told that the Health and Hospitals Corporation has shortages of funding, okay? And even when they get that shortage down, it means cutting services. So if you're applying this to pregnancy outcomes, okay, how do you go to Health and Hospitals Corporation and say, we want more money for pregnant women as opposed to anything else that we need here? How do we sort of, it's almost like robbing Peter to pay Paul, but how do you end up doing something like that with the powers that be?
Did everyone hear the question? Okay. So thank you for that. For me, it's really, my answer is often organizing. We can't do enough organizing around these issues and getting them to see that they are connected to other things that, it's not just about the pregnant person, it's about just a whole range, and a lot of times the root causes have to do with so many other larger issues. So that's why we do things that are tied to electoral politics, and we make sure that people get out, not just voting every 4 years, but that kind of really long haul grooming candidates, who we just elected in Congress, a lot of them were informed by reproductive justice activists. People don't know that Stacey Abrams, the people who were supporting her to become governor, she didn't win, but she came pretty close, and her election was stolen, in my opinion. So, but people don't know that people are doing groundwork that takes a long time. And that's the only time we've ever done anything before. If you look back in history, anytime we've won any major, significant, ground-swelling social change, it's because people were in it for the long haul, and they mobilized sometimes around a crisis, unfortunately. But then that's what it requires, and I think educating more people about their rights and supporting people to do that. Because it's also more than about services, because even when we have the services, I was trained as a human service professional, and I was told my job is to work myself out of a job, not into one. And I still believe that, that I want to live in a world where we don't need so many services because people have what they need in their own, families and communities, and they're supported to do that. And I do believe that these things are possible. They're aspirational, but I don't, what's a heaven for, right? So I think it's right here.
Well, Lynn, I understand that you have a class.
I do.
Keeping you from your
I have students who are,
Yeah. So
facilitating without me until I get there.
before you go, we'd like to make a little presentation to you.
Thank you.
Thank you.